Good afternoon, everyone, and welcome to today's webinar on Ebola Essentials for Nurses, Awareness, Preparedness, and Safe Practice. I'm Joey, and I'll be your moderator. Thank you for joining us for the essential discussion about one of the world's most challenging infectious disease. During your pre-registrations, you asked about caring for vulnerable populations, protecting our families, understanding NCID protocol, and how to prepare your hospitals coordinate outbreak responses. These are real world challenges you face, and we hope to address them today. I'm honored to represent the Center for Asian Nursing Studies, CANS, as we host this conversation. We are established in 2016 with a vision to catalyze great nursing for humanity. Our mission is to create a learning ecosystem for Asian nursing and beyond, working to shape the future work of nurses, grow the future workforce, and design the future workplace. Today's webinar is particularly timely. Just months ago, in September 2025, the Democratic Republic of Congo declared its 16th Ebola outbreak since the virus was first discovered there in 1976. With 64 confirmed cases and 43 deaths, including 5 healthcare workers, 4 of whom were nurses, this reminds us that Ebola remains a clear and present danger to global health security. But here's what's different now. We are no longer unprepared. The lessons learned from the devastating 2014 to 2016 West African outbreak, claiming over 11,000 lives, have transformed our approach today. We have effective vaccines and evidence-based protocol that can improve outcomes. With this, I'm very honored to introduce our speakers from National Center for Infectious Disease, NCID, who bring both deep expertise and frontline experience to today's discussion. NCID houses Singapore's only high-level isolation unit and serves as our center for excellence in managing high-consequence pathogens like Ebola. Assistant Nurse Clinician Ms. Meng Ya and Staff Nurse Tan Jia Yi will guide us through the comprehensive overview of Ebola virus disease. They bring extensive experience in infectious disease nursing, and we will be addressing your questions in the chat during the Q&A after the sharing, so feel free to use that today. Um, the speakers will not only let us understand what Ebola is, but also how, as healthcare professional, how can we protect ourselves, our patients, our family, and our community. Staff Nurse Jia Yi.
First, I'll start off today's session with the introduction to the Ebola virus disease, known as EVD. Followed by its epidemiology, we will also cover the history and recent Ebola virus outbreak, the pathophysiology, clinical features and complications, diagnosis and management, as well as the nurses' roles and responsibilities. Last but not least, the Singapore National Centre of Infectious Disease, NCID roles in the national preparedness. So, what is Ebola virus disease? The EVD is a severe illness with high fatality rate. Its epidemiology is characterized by sporadic outbreaks, primarily in Central and West Africa. It originates from the initial zoonotic transmission, which is from animal, and it is sustained by efficient human-to-human spread. Now, we will move on to the epidemiology of the EVD. The Ebola viruses belong to a family of viruses known as Filoviridae. There are a total of 6 species of Ebola virus. First, we have the Zaire Ebola virus, Sudan Ebola virus, Bundibugyo, and Thai forest Ebola virus. And these 4 species are known to cause disease and pathogenic in humans. The other 2 species are the Reston and Bombali Ebola virus, which are not known to cause illness in humans, despite evidence of human infection in some cases of Reston and Ebola virus. I'd like to highlight on the Zaire Ebola virus. It is known the primary pathogen as it is the most common and virulent species for major outbreaks. It is responsible for the largest outbreaks in West Africa epidemic occurred in 2014 to 2016, as well as multiple outbreaks in the DRC, which is the Democratic Republic of Congo. It has also caused a recent outbreak occurred in 2025 in Kasai Province, DRC, which will be discussed further in a while. Now, we will move on to the epidemiology of the EVD. and we will be focusing on the ecology and transmission of the disease. Fruit bats are the natural reservoir for the Ebola virus. Bats carrying the virus can transmit it to other animals like apes, monkeys, and antelopes. The animals usually get infected by eating fruit bats or fruit contaminated with bats' saliva. Then, a spillover event occurs when human contact with infected animals. The first human who got transmitted immediately became a primary case, leading to an efficient human-to-human transmission through contact with blood, bodily fluids, or contaminated materials. The Ebola virus is more sustained and prolonged in human transmission chains. Human-to-human transmission may occur through direct contact with blood, secretions, or other bodily fluids of infected person. Indirect contact with contaminated surfaces or materials such as bedding and medical equipments. Transmission can also happen during viral rituals that involve direct contact with the disease. Next is through sexual transmission. And lastly, via mother-to-child transmission and during breastfeeding. The high-risk groups include the healthcare workers who have close contact with infected patients, family members and caregivers who care for the sick individuals, as well as individuals who handle the bodies of deceased during the burial ceremonies. The virology. Ebola virus is an enveloped filamentous virus measuring about 80 nanometers in diameter and up to 1,400 nanometers in length. It contains single-stranded negative sense RNA genome, which allows the virus to rapidly replicate and spread within the host. Now, we'll look at the case fatality rate of each Ebola virus species. Case fatality rate, known as a CFR, represents a proportion of individuals diagnosed with the disease who die from it. Based on the data from previous outbreaks, the CFR varies significantly between different species of Ebola virus. The Zaire Ebola virus is the most deadly and commonly responsible for major outbreaks. The CFR has ranged from 25% to as high as 90%. Next, the Sudan Ebola virus. This species has also caused severe disease with reported fatality rates ranging from 41 to 70% in the past outbreaks. The Bundibugyo Ebola virus is generally considered the least severe among the Ebola species that is known to infect humans. The average CFR of this Ebola virus was approximately 33%. As for the Thai forest Ebola virus, there has only been one reported human infection, which was non-fatal. Hence, the CFR is at 0%. Despite these differences, the CFR for Ebola virus disease remains high. Early supportive patient care and treatment may increase the chance of survival from severe disease and improve the CFR. The basic reproduction number in the past outbreaks has typically been estimated between 1.5 to 2.0, meaning with each infected person, it can spread the virus to 1 to 2 others on average. This indicates potential for rapid epidemic growth if it is not being effectively controlled. Super spreading events. Another key feature of EVD epidemiology is that with a small number of cases, it can lead to a large proportion of transmission. This often happens in healthcare settings or during funerals, as it can be responsible for a large proportion of transmission, as this is known as the super spreading events. History of outbreaks. The Ebola virus disease was first identified in 1976 in 2 simultaneous outbreaks. One outbreak was of Sudan Ebola virus in South Sudan, and other outbreak was of Zaire Ebola virus in the Democratic Republic of Congo, known as DRC. This outbreak occurred near the Ebola River, after which the disease was named. The Ebola virus is one of the world's deadliest pathogens with a fatality rate of up to 90% without treatment. These maps show a Ebola virus outbreaks by virus species and the number of cases reported since 1976. It highlights the cases reported it highlights that outbreaks have occurred throughout the Western and Central Africa, with areas marked in orange indicate that most outbreaks were caused by the Zaire Ebola virus disease species. Other significant outbreaks resulting in hundreds of cases have occurred in the Democratic Republic of Congo, The virus has also caused smaller outbreaks in several other African nations, including Uganda and South Africa. The largest Ebola outbreak occurred in West Africa from 2014 to 2016. Despite having the highest number of infected cases, the CFR was 39.5. During the 2018 to 2020 period, the DRC experienced its 10th Ebola virus disease outbreak, which is considered as the second largest EVD outbreak worldwide. As you can see, the number of cases here was lower, but the number of deaths was higher, resulting in a higher CFR with a number of 66%. In contrast, the outbreak showed a much higher CFR despite having fewer cases. Now, we will discuss on the recent Ebola outbreak in Kasai province of DRC. On the 4th September 2025, the DRC Ministry of Health officially declared an EVD outbreak in the Kasai province, and the World Health Organization, WHO, had been alerted since the 1st of September. The first known case was a pregnant woman admitted on the 20th of August, presented with bloody diarrhea, hemorrhage, vomiting, asthenia, followed by multiple organ failure. She was pronounced dead on the 25th of August 2025. On the 3rd of September, the National Public Health Laboratory confirmed Ebola virus, again a Zaire strain, in 5 blood samples using the Gene Expert and PCR assay. This whole genome sequencing indicates a new zoonotic spillover, which means it is not related to the previous outbreaks that occurs nearby. Transmission to humans is likely through contact with infected wildlife, then human to human via bodily fluids, and healthcare workers have also been infected in this outbreak. As of the 7th of October 2025, there were a total of 64 confirmed cases, including 43 number of deaths, resulting in a CFR of 67%. The WHO assessed the public health risk as high at the national level, moderate at the regional level, low at the global level. The WHO and DRC Ministry of Health had taken leads to response efforts that includes contact tracing, vaccination of frontline workers, and close contacts, deployment of treatment centers, community engagement and isolation measures. And finally, these outbreaks mark the 16th Ebola outbreak in the DRC since the virus was first discovered. Here's the latest update of the recent outbreak. The DRC discharged its last infected patient on the 19th of October 2025, initiating a 42-day surveillance period. It is a time frame representing 2 times the virus' 21-day incubation period, before the outbreak can be officially declared over. Healthcare workers were significantly being affected, with 5 cases among the staff, which are 4 nurses and 1 lab technician, 3 of whom had died. Despite operating in a remote area with poor road infrastructure, authorities rapidly deployed a 32-bed treatment center within days of the first case identification. Vaccination had reached over 35,000 people within 6 weeks. This has marked the second Ebola outbreak in 2025. Lessons learned from the past outbreaks. Let's take the 2014 to 2016 Ebola outbreak in the West Africa as an example. Back then, a slow and fragmented international response combined with overwhelmed and local health systems led to a catastrophic epidemic with over 11,000 deaths. This results in the devastating social and economic impacts and a loss of trust in the healthcare authorities. The war was unprepared. It highlighted the significant gaps in global health unpreparedness. In the past, there were no vaccines or specific treatments available for Ebola. Today, we have highly effective vaccines and therapeutics that enable a proactive and life-saving response. Previously, the outbreak response was largely reactive, meaning that response only began after cases were detected. Now, there's proactive investment in high-risk countries to strengthen the surveillance, labs, and rapid response team. Earlier outbreaks were also challenged by fear, mistrust, and resistance from communities. Now, engaging in communities from the very beginning is a key strategy to build trust and to ensure the effectiveness of response measures. Before this, The response was often delayed and poorly coordinated. Today, outbreaks benefit from faster, more organized action led by the national governments with strong support from the international partners. Control and prevention. An outbreak control relies on the classic public health measures that involve case finding to actively search for new cases to understand outbreak spreads. Isolation of infected individuals from the community to halt transmission, contact tracing by identifying those who had close contact with confirmed case, and to ensure a safe and dignified burial practice that do not involve the contact with the disease. Prevention and strategy via ring vaccination. It involves vaccinating a ring of close contacts around a confirmed case and healthcare workers. This strategy using the available vaccine is highly effective at breaking chains of transmission. In addition, there's also monoclonal antibody treatments, for example, the Imazep and Imanga. It has significantly improved survival rates for infected individuals by targeting and neutralizing the virus. Moving forward, we will be focusing on the pathophysiology of EVD. First, the virus enters the body through the skin or mucous membrane and immediately targets the immune cells such as the macrophages and dendritic cells. The virus replicates efficiently within the immune cells, which then triggers the cytokine storms, which is a massive inflammatory response. Then, the Ebola viral proteins interfere with the host immune system by blocking the production of interferons, which prevent the activation of other immune responses. Infected immune cells transport the viruses throughout the body, leading to widespread systemic infection. The virus also affects the endothelial cells, which leads to a vascular leakage. All these events cause the necrosis and dysfunction of organs such as the liver, lymph, and adrenal glands. Liver failure leads to a disseminated intravascular coagulation, and all these effects leads to a failure of the coagulation system, compromising the body's ability to form blood clots. This leads to internal and external hemorrhage, hypotension, and shock, resulting in multi-organ failure and a major cause of death in severe cases. Clinical features of EVD. The incubation period of EVD ranges from 2 to 21 days, with an average of 8 to 10 days after exposure. During this period, infected individuals are asymptomatic, hence there is no risk of disease transmission as the level of virus in the body is very low. Initial symptoms typically appear within the first 0 to 3 days of infection. These symptoms include fever and chills, weakness, fatigue, headache, and sore throat. When infected individuals start showing symptoms, they begin to be contagious, and the risk of transmission starts and increases with the disease severity. On day 3 to day 10 onwards, the infected individuals begin to experience mild to moderate symptoms such as maculopapular rash at around day 5 to 7, loss of appetite, nausea and vomiting, abdominal pain, as well as diarrhea. There is a moderate to high risk of transmission to others during this phase. Severe symptoms begin to develop around day 7 to day 12 of infection, such as hemorrhagic manifestation, which is unexplained bleeding that includes PIT-K and ecchymosis, mucosal bleeding in the gums, and as well as internal bleeding. During this stage, the risk of transmission to others is extremely high. I would also like to highlight that the development of maculopapular rash serves as a key diagnosis clue for the disease. Death usually occurs between day 6 to 16 from the onset, as the patients with fatal disease usually develop more severe clinical signs, including multi-organ failure, septic shock, and diffuse coagulopathy. In non-fatal cases, patients may have fever for several days and improve, typically around day 6. But the survivors may have prolonged period of recovery. Complications of EVD. After recovery from Ebola, many survivors experience neurological issues such as headaches, memory problems, peripheral neuropathy, and tremors. Less commonly, some may develop muscle weakness, seizures, and Parkinson's disease. Eye-related complaints are also frequent, including pain, redness, dry eyes, sensitivity to light, and blurred vision. More serious eye conditions like uveitis, cataracts, and diseases affecting the retina or optic nerves can also develop either during the illness or sometime after recovery. Over 35% of survivors report hearing problems such as tinnitus or even hearing loss. Muscle and joint pain are very common, affecting 50 to 75% of survivors. Some also experience tenosynovitis, which is the inflammation of tendons, or costochondritis, which is the chest wall pain, with occasional signs of arthritis. Many survivors report abdominal pain, but exact causes remain generally unknown. The experience of surviving Ebola can be traumatic. Survivors often face emotional challenges from the severe illness, isolation during treatment, witnessing of the death, and social stigma after returning home. This leads to a high rate of grief, anxiety, depression, PTSD, sleep disorders, substance use, and even suicidal behaviors. Children are especially at risk due to separation from caregivers and loss. Issues such as erectile dysfunction, testicular or pelvic pain, and menstrual irregularities are also frequently reported. Now, I'd like to pass my time over to Meng Ya. Thank you.
Thank you, Jia. Next, I will start with the diagnostic tools that is used for confirmation and monitoring of the disease. First of all, the real-time RT-PCR, which stands for Reverse Transcription Polymerase Chain Reaction. This is the preferred standard laboratory method for Ebola diagnosis. It is highly sensitive and specific, capable of detecting very low concentrations of the virus, which is critical for early diagnosis. However, this tool also requires a fully equipped laboratory, trained personnel, strictly controlled conditions, continuous power supply, proper maintenance, and a reliable cold chain for reagents, which are the conditions not always available in outbreak settings. Next, we have rapid antigen detection tests, also known as RDTs. Unlike PCR, these tests detect viral proteins or antigens rather than viral RNA. They are particularly useful for rapid screening in the field or in remote settings where laboratory capacity is limited. An example of such a test is the Aura Quick Ebola Rapid Antigen Test, which can deliver results in about 30 minutes time using either blood or saliva samples. However, WHO does not recommend using this test for routine diagnosing when PCR testing is available due to its low sensitivity compared with molecular methods. Next, we have serology using ELISA to detect IgM and IgG antibodies. This method is mainly used to diagnose past infections or resolving infections. It is not very useful during the early phase of illness, as the body's antibody response takes time to develop and may not yet be detectable. Lastly, we have multiplex or automatic cartridge systems, such as the Iceberg Ebola assay. These systems combine RNA extraction and RT-PCR amplification within a single cartridge, automating the process. This not only speeds up turnaround times, but also reduces the manual handling steps, which helps minimize the risk of cross-contamination. Such systems are particularly suitable for near point of care or field laboratories with limited infrastructure, providing reliable molecule testing outside of fully equipped central labs. However, the Jenny expert systems also has its limitation. It is costly to implement, relies on proprietary cartridges, and may not detect all virus strains during the early stage of the outbreak. This slide provides an overview of the 4 diagnostic tools, highlighting what each detects, the types of specimens, and turnaround time, as well as their respective advantages and limitations. As mentioned, real-time RT-PCR and Jenny expert RT-PCR are highly accurate diagnostic tools. However, it is costly and requires skills, infrastructure, or supply. RDTs and ELISA may have some advantages, but not useful for early diagnosis. Next, we will turn our attention to the management of Ebola virus disease, comparing the recommendations provided by the World Health Organization, WHO, and the Centers for Disease Control and Prevention, CDC. Let's begin with primary documents and their current status. For clinical management of Ebola, the WHO provides living guidance, which is continuously updated to reflect the latest evidence and recommendations. There is also a related infection prevention and control, IPC guidelines, developed using the GRID approach, which is the most recent version published in 2023. In addition, the early WHO pocket guides remains a useful resource for frontline workers, offering concise, practical guidance in the field. The CDC's clinical guidance for Ebola disease is maintained on the CDC website and includes dedicated pages on viral hemorrhagic fever infection control and clinical care. It is regularly updated as outbreak occurs and as new scientific knowledge becomes available. The guidance provides practical recommendations covering clinical care, laboratory testing, and public health strategies for Ebola management. Regarding scope and audience, the WHO guidance targets a global public health and clinical audience. It is intended to be adapted by national program and used by frontline clinicians during outbreaks, particularly in resource-limited settings, as well as in specialized units such as Ebola treatment units, EDTs, and high-level isolation units, HLIUs. A key emphasis of the guidance is the need for adaptation to the local context, ensuring recommendations are practical and feasible for the settings in which they are applied. The CDC guidance is primarily aimed at healthcare facilities and public health partners in the United States, though it is also used internationally. It focuses on hospital preparedness using a tiered approach, providing detailed clinical actions tailored to US settings, along with guidance for public health authorities to coordinate effective outbreak response. Moving on to the overall clinical management approach, the WHO living guidance outlines comprehensive supportive care for patients with Ebola. This includes aggressive management of fluids and electrolytes, provision of oxygen, close monitoring, and timely management of complications. Where evidence supports their use, the guidance also provides recommendations on specific therapeutics. A key principle is holistic care, ensuring that interventions are appropriate to the available resources and context of care. Similarly, the CDC emphasizes aggressive supportive care for patients with Ebola. This includes fluid resuscitation, electrolytes management, hemodynamic support, and management of organ dysfunction. The guidance also outlines when should be clinicians consult public health authorities or the CDCs regarding the use of therapeutics and decisions on advanced supportive measures. Regarding therapeutics, the WHO living guidance provides evidence-based recommendations for agents active against Zaire Ebola virus. For example, certain monoclonal antibodies have demonstrated benefit in clinical trials. The guidance recommends only those therapeutics with proven mortality benefit and is regularly updated as new evidence become available. For CDC guidelines, it summarizes the therapeutics that are currently FDA approved or recommended for Zaire Ebola virus. It advises healthcare providers to notify their local health department or the CDC to determine the appropriate treatment course. CDC guidance also provides links to FDA approval and treatment options and emphasizes consulting experts to ensure safe and proper access and use of these therapeutics. Turning to infection prevention and control, the WHO IPC guidance published in 2023 provides detailed grid-based recommendations. It covers the use of personal protective equipment, PPE, engineering controls, safe care practices, waste management, and environmental cleaning. Importantly, It also addresses the protection of health workers in both ETU and frontline healthcare facilities. A key principle of the guidance is to implement measures that are appropriate to the available resources in each context. The CDC provides detailed IPC recommendations tailored to US hospitals and other healthcare settings. This includes a tiered approach to preparedness, guidance on airborne versus contact precaution depending on the contact, and clear instructions on donning and doffing of PPE. It also covers the use of dedicated patient rooms, proper waste handling, and special procedures for high consequence pathogens, all of which are detailed on the CDC viral hemorrhagic fever pages describing hospital readiness. Regarding vaccination policy, vaccines are used primarily as outbreak response tools. 2 WHO-approved vaccinations are available for Zaire Ebola virus. Ebola is a single-dose vaccine used for vaccination of high-risk populations during outbreak. The Jack Daniel and Vibria vaccine regime involves 2 doses. WHO recommendations take into account the virus species, the vaccine availabilities, and the specific outbreak context. The guidance also highlights differences between vaccine products and their respective roles in outbreak control. The CDC provides public health guidance on Ebola vaccination, including information on available vaccines and consideration for post-exposure vaccinations. It also links to the current US regulatory status of this vaccine and emphasizes the importance of coordinating with public health authorities when planning vaccine deployment during an outbreak. Regarding the care of Ebola survivors, the WHO recognizes that post-Ebola sequelae can affect multiple organ systems. The guidance promotes comprehensive survival care and encourages integration of follow-up services into routine health systems. It also provides recommendations for safe care in situations where the virus may persist in immunoprivileged sites. The CDC provides practical guidance for the care of Ebola survivors. It emphasizes standard precautions for routine healthcare. It offers specific recommendations for situations where persistent viral RNA or ongoing clinical issues may be present. Importantly, the guidance promotes ensuring that routine healthcare is not withheld from survivors. Regarding the evidence approach and updates, as mentioned, the WHO used a living guidance model combined with the GRID methodology for its IPC guidance. Recommendations are regularly updated as new trial results or other data emerge. The guidance also encourages adaptation at the national level to suit local contexts and resources. The CDC maintains its Ebola guidance on the web, updating its new as this new evidence emerge or regulatory changes occurs. The guidance is practical and more action-oriented, providing clinician and public health partners with direct links to federal-approved advisory and laboratory alerts. Finally, some practical differences clinicians should note. The WHO emphasizes adaptability to low resources or outbreak settings. This includes pragmatic options for fluid management, such as oral rehydration, and IO assays, simplified monitoring approaches, and other strategies suited to constrained environments. Overall, the guidance provides global policy recommendations that can be adapted to local context. In contrast, the CDC emphasizes hospital preparedness in high resources settings. This includes the designation of specialized facilities, use of trained isolation teams, availability of advanced organ support, and close coordination with public health authorities and federal agencies to ensure safe and effective patient care. Next, we will explore the nursing roles and responsibilities in the care of patients with Ebola. First, regarding preparation and training, The WHO emphasizes that nurses should adopt safe care practices to protect themselves while delivering care. They must take appropriate precautions and ensure that the care is provided with dignity, even in high-risk settings. The CDC also emphasizes that nurses must be thoroughly trained and competent in infection control practices, with special attention to the correct donning and doffing of PPE when caring for patients with Ebola virus disease. The training is essential to minimize the risk of exposure and maintain safety for both healthcare workers and patients in high-risk settings. Regular training, drills, and competency in PPE are essential, and mentorship and audits reinforce safety, and adherence to the protocol can prevent errors. For allocation and staffing, according to the WHO, care may need to be delivered in settings with limited resources, where nursing roles may be streamlined to maximize the efficiency. Healthcare workers, including nurses, play a central role in providing safe, effective care under these challenging conditions. From the CDC perspective, nursing roles within a designated biocontainment unit for Ebola care are clearly defined. Both WHO and CDC recommends using dedicated trained team to care for suspected or confirmed Ebola patients. This includes maintaining dedicated roster or search pools, limiting the numbers of healthcare workers entering the patient's room to essential personnel only, and assigning staff based on zones or cohorts. Roles are allocated according to function to optimize safety and efficiency while minimizing the exposure risk. Regarding infection prevention and control, biosafety, the WHO emphasizes the consistent application of standard and transmission-based precautions. This includes strict hand hygiene, safe handling of body fluids and contaminated linens, and fully adherence to PPE protocols and environmental safety measures to protect both healthcare workers and patients. From the CDC perspective, infection prevention and biosafety for Ebola care includes supervised donning and doffing of PPE, controlled entry and exit of designated zones, and ongoing monitoring for potential exposures. Additionally, nurses play a central role in IPC for Ebola. Key responsibilities include promptly identify and triage suspected cases, and isolating and cohorting suspected or confirmed patients with dedicated staff and equipment. It is essential to maintain a clear separation between clean and contaminated zones, restrict access to high-risk areas, and ensure all staff are trained in IPC procedures. Strict adherence to PPE protocol, like donning and doffing, must be performed under supervision, often using a spotter or buddy system. Barrier nursing principles are applied to avoid skin exposure and prevent unnecessary adjustment to PPE during the patient care. In addition, effective IPC also relies on environmental and operational measures. This includes using dedicated medical equipment within isolation areas and ensuring proper disposal of contaminated waste, linens, and sharps, while maintaining sharp safety and safe handling of blood or body fluids. Regarding environmental cleaning and maintenance of decontamination zones are essential, including proper decontamination of ambulance and patient transfer routes. Compliance is monitored through regular audits and feedback, alongside ongoing IPC and biosafety training and drills. Hazard assessment and exposure risk management involve identifying high-risk tasks, such as evaluating the risk of spillage and contact with body fluids or aerosols. PPE and safety protocols are then adjusted accordingly to mitigate this risk. Next, we will share with you the PPE protocols and the components of Tier 1 PPE using in NCID as an example. At NCID, PPE used required proper training and supervisions to ensure that safe donning and doffing at all the times. Tier 1 PPE is used for high-level isolation pathogens such as Ebola. This includes both airborne and contact precautions with full coverage of all skins. There are two versions of Tier 1 PPE, with or without PAPR, depending on the level of exposure risk. For direct contact with patients, samples, contaminated equipment or environmental waste, Tier 1 enhanced PPE without a powered air purifying respiratory PAPR is used. Tier 1 PPE with a PAPR is reserved for procedures with aerosol risk, such as the nasal pharyngeal swab or intubation, and also for prolonged use. For example, if the nurses need to stay in the patient's room for 4 hours, they have to wear a Tier 1 with PPR. For documentation and continuous patient monitoring, it's also vital in Ebola care. WHO emphasizes accurate records, early detection of complications, and close observation for transmission risk. CDC aids the need to log staff entry and exit, PPE breaches, and safety checks to protect healthcare workers. Nurses must document all care activities precisely, monitor vital signs and fluid balance, and provide IV or oral rehydrations as needed. They manage symptoms such as shock, hemorrhage, or organ dysfunction, administer prescribed medications, and ensure nutrients and wound care to prevent complications and maintain patient safety. Communication and coordination are equally important in Ebola nursing care. WHO emphasizes the nurses' role in liaising with healthcare teams, engaging patients and families with dignity, and supporting community efforts. CDC highlights collaboration between doctors, pharmacies, infection control teams, and laboratories, with the primary nurse coordinating overall care. Nurses serve as key links among patients, the medical team, and allied health staff, ensuring clear handovers, effective communication, and adherence to infection control and PPE protocols. Additionally, nurses also help to manage PPE use, logistics, and resources to ensure safe and efficient care delivery. Next, we're going to talk about well-being and occupational safety in Ebola care. The WHO emphasizes adequate staffing and maintaining staff working conditions in high-risk outbreak settings. The CDC highlights fostering a culture of staff safety, empowering personnel to raise concerns, ensuring structured roles with supervision, and preventing fatigue or overload among healthcare workers. Nurses are responsible for self-monitoring and must immediately report any exposure incidents. Psychological support and fatigue management are important to maintain well-being during high-risk care as well. Maintaining vaccination status, adhering to prophylaxis protocols is, if applicable, and particularly and participate in periodic health monitoring are essential of self-care and occupational safety. Lastly, we're going to talk about the nursing roles in follow-up care. Nurses coordinate discharge and post-discharge follow-up cares to ensure recovery and safety. Discharge is considered when the patient has been afebrile for at least 3 days, shows no symptoms suggesting viral shedding, demonstrates clinical improvement, and can perform daily activities independently. A negative blood PCR after symptoms resolution is required. Nurses also educate patients that the virus may persist in sets such as semen, eyes, brain, or breast milk. Last but not least, nurses will also need to ensure proper disinfection after patient discharge and assist in safe closure of the Ebola unit. Now we have reviewed the nursing roles in Ebola care. Let's see how these practices align with Singapore's national preparedness efforts led by National Centre for Infectious Disease, NCID. NCID plays a central role in Singapore's national preparedness for infectious disease, including Ebola. NCID features 17 specialized wards and 330 beds. Officially opened in 2019, it operates under the National Healthcare Group and serves as the primary responder and leading institution dedicated to manage and controlling infectious disease in Singapore. It provides specialized clinical care and houses the nation's only high-level isolation unit, enabling the safe management of patients with high-level isolation pathogens. HLIU is equipped with biocontainment units, and highly trained staff who manage clinical samples through on-site laboratory testing and ensure safe handling of waste and environmental decontamination using tools such as autoclave. NCID also plays a key role in training and education. The center provides training programs for healthcare professionals to enhance the Singapore's national infectious disease response capacity. It develops guidelines and protocols for infections prevention and control, and conducts frequent simulation exercise to prepare our staff for potential outbreaks, ensuring that both clinical and operational teams are ready to respond effectively. NCID collaborates closely with the Ministry of Health and other government agencies to ensure coordinated outbreak preparedness. NCID also supports the development of policies and strategies aimed at mitigating the impact of infectious disease, strengthening Singapore's overall national response capabilities. In summary, effective Ebola management relies on preparedness, teamwork, and strict adherence to established guidelines. Both the WHO and CDC emphasizes the importance of evidence-based clinical care, excellence in IPC, and protection of healthcare workers from exposure. In addition, continuous training, simulation exercise, and system-level coordination are essential to sustain preparedness. Ultimately, success depends on strong interdisciplinary collaborations across clinicians, nursing, allied health, and laboratory teams, ensuring safe and effective care for patients by minimizing risk to staff and the community. This concludes the presentation. Thank you for your time. And now I will pass back to the moderator.
Thank you, Staff Nurse Jia and ANC Meng Ya for their very generous sharing of knowledge about EVD. They provided comprehensive insight covering the origins, the transmission pathway, pathophysiology on the human body, and also the various complications that arise from the viral infection, and as well as the comprehensive management on treatment and containment. We'd like to thank the participants as well who reported the connectivity issues during today's session. We apologize for the network difficulties experienced by some attendees, but are pleased to know that the majority are not affected. For those who encounter technical problems, be assured that the session is recorded and we will share the recording via our LinkedIn page. And if you experience any issues submitting your CPE today, then you can contact us via email. So thank you for your patience. What we have just learned from our incredible speakers is that all these underscore a very sobering reality. Ebola's case fatality rate of up to 90% makes it one of the world's deadliest pathogens. When we are dealing with such high mortality rates, every protection measure becomes critical, especially for our most at-risk patient. So the progression that we've just seen from initial flu-like symptoms to hemorrhagic manifestations highlight the importance of early detection and healthcare system preparedness. These symptoms can also be mistaken for common conditions, making your clinical judgment absolutely critical. Moving from understanding the enemy to fighting it, some of the clinical principles that we are about to discuss directly answers your question about the supportive care that you sent in before the webinar. So now let us move to our panel discussion. We are quite cognizant of time. We may have a limited choice of questions, but let me please to inform you we have with us Dr. Margaret Soon, Director of Nursing at the National Centre for Infectious Disease and Head of the Infection Prevention Control and Outreach Office of NCID ICON. Ms. Chen Hong, Advanced Practice Nurse, and Mr. Lucius, Advanced Nurse Clinician, Assistant Nurse Clinician from NCID as well. Your question will take the center stage in this discussion, and you feel free to put into the chat box. So the Q&A icon is located at the bottom of your screen, and we'll be collating your questions together and address them collectively in view of time constraint, but you can continue to submit your additional questions that may arise. Okay, I'm reading not much question online, but we do have some prepared questions. So I would like to ask Lucius this question: when and how are Ebola patients transferred to NCID, and what are the specific transfer procedures and safety requirements?
Thank you for the question. So how and when are Ebola patients transferred. So in NCID HIU nursing, we have protocols and guidelines in place to transport patients from various locations in Singapore. As mentioned by our speaker, we work closely with other agencies for a coordinated outbreak response. So we work with a specific private ambulance to facilitate transport of suspected Ebola cases. They can be transported from anywhere in Singapore, be it from the airport or public health institutions, or in short, PHIs. Recently, we have been running simulation exercises with the private ambulance to run audits and ensure that the ambulance staff involved are competent in their PPE donning and doffing and their overall transfer process. During these simulations, we not only audit the ambulance staff, but also other stakeholders like security, housekeeping, HIU nurses, and even the medical staff. This is to ensure that all personnel involved are competent and prepared to receive suspect case in NCID. For suspect cases that come to our site in NCID, they are transported in a portable medical isolation unit, which is in short PMIU, and the patients are only exited out of the PMIU once they reach the patient's room. And of course, all our staff in HIU and the ambulance staff go through frequent competency assessments to ensure that their donning and doffing of the PPE is safe, and their transfer process are regularly audited and ensure they are safe for patients' transfer. Yep, I hope I have answered the question.
I think you have absolutely hit the spot of the question. Thank you very much. I saw a very interesting question. What are some of the early clinical signs and symptoms of Ebola, and how can they be distinguished from other febrile illnesses such as malaria and dengue? I think this is a very, very interesting and very needful questions. How do we detect? Maybe can I invite APN Chen Hong to answer this question?
Oh, thank you for asking the question. I hope you can hear me well. I feel this is $1 million question because, in fact, Ebola, the very first onset of symptoms are actually very, very non-specific. So what do we mean by that is, if you think about it, fever, feeling cold, body ache, right? This is a very viral picture of presentation, which is probably can't be really differentiated from malaria or dengue at the very beginning also. So that's why a clinician need to maintain a very high clinical suspicion, need to gather a good travel history, understand the risk exposure, and then have a high suspicion to test for a broader range of differential. So thanks for the question. I hope that answers that.
Thank you so much for addressing that question. I think we have some time now. We have about 3 minutes, right? I have one question from Ong Wei Wei. Okay, there's a staff and manpower for infectious case and disease outbreak. I think essentially Wei Wei like to ask how do we ensure NCID staff can go home at the end of the day with their family? So it's like the scenario is like if they have newborn baby especially, how can they remain safe and go home after a work shift and still keep their families protected? Can Ms. Meng Ya help us to understand how?
It is safe for a nurse who has just cared for Ebola patients to return home, including that if let's say the household is with young children or infant, as long as the staff is following the proper infection control and prevention practices, and then all the healthcare workers who are allowed to take care of Ebola patients are actually trained to use the strict IPC measures, including those proper PPE, safe doffing procedures and hand hygiene, etc. And these precautions are designed to prevent exposure. And if let's say there is a breach, although should not to, the institution should also have protocols for it for the staff to follow.
That's very reassuring. Thank you. Okay, I see that there's no new question, but I do prepare one for our Dr. Margaret Soon. She specially took time to join us, so we should hear from her wisdom. So this is about, let me scroll. This is about how should community, this is one of the questions that was submitted pre-registration. How should community hospitals and healthcare facilities also prepare for these potential Ebola cases, including radiology protocols, infection control measures, managing the psychological impact on the healthcare worker, coordinating especially on the community outbreak response strategy? Yeah, I think this is very important question because yes, NCID is very equipped, but how does community, tackle this very sounds like a very critical problem? Dr. Margaret, please.
Thank you for the question. I think first I'd like to caveat that actually not just community hospitals need to be prepared, but really everyone should be prepared for any emerging infectious diseases that will come into any of our facilities or any of the countries. So being always on the lookout is actually one of the most fundamental requirements in pandemic preparedness. So whenever we talk about being prepared for any diseases, whether it's a pandemic or just an emerging infectious diseases, we always talk about mitigating, preventing it from happening if we can at all prevent it from entering our doorstep. But otherwise, if we cannot mitigate it, we need to be prepared for it. And so in preparedness, we talk about system preparedness, people preparedness, as well as resource preparedness. So for system preparedness, we're talking about surveillance, knowing when something is not right, being able to identify when something is threatening, emerging. So for example, knowing that there's an outbreak in another country will help us to be prepared, because then we will know what to look out for. And there are many other aspects of system preparedness. This is just one example. In people preparedness, we hear about the importance of making sure that we know our IPC protocols, being trained for it. I think our earlier speakers have actually alluded to the importance of knowing and being prepared, being trained, and ensuring that all these are prepared before it even happens. And in terms of resource preparedness, we're talking about ensuring that we have the PPEs that we need to use, having the medication, the therapeutics, should it come to our country or our hospital, those therapeutics are available. So ultimately, it is really a very holistic approach, and everyone and anyone should really be expecting something to land in our doorstep and always being prepared for it. Thank you.
I think it's an excellent response. Today, as we conclude our webinar, I hope we have provided you answers that you can use back at your work area. Let me leave you with some key takeaway that will directly address your concern. Remember, the speakers talk about your nursing skill, your assessment, your comfort care, your family support is even more critical when curative options are limited. You are often the difference between a patient dying alone and a patient dying with dignity. So there's the perfect PPE technique isn't just about following protocol. It's going home safely to the people you love. So practice well until it's automatic, because in a crisis, you'll default to your training. I think the third point is knowing about your facilities activation procedures now before you need them. Because NCID is Singapore's safety net, but the initial recognition and stabilization happens with you. Now, every facility can implement basic Ebola readiness measures and start with what you can control, which is training, protocols, and communications, and build from there. I think the fifth point is that remember from Dr. Margaret, Ebola outbreaks can be stopped by a healthcare worker like you, and following protocols like the one we discussed today, one patient at a time. I want to thank our exceptional speaker for addressing their specific concerns, and our audience for asking the questions that matter. Your engagement today showed a proactive and thoughtful approach that will keep our community safe. When you leave this webinar, I'd like you to know about our upcoming webinar on changing climate, green care and healthy future in January 2026, as well as workforce leadership, focusing on blueprint of future healthcare leaders, intergenerational workforce, and the slide that you are waiting for now, CP point. We will invite you to stay connected with us as well on LinkedIn, where we will be posting today's recorded session. Once again, you came here with concern, and I hope you are leaving with confidence that you can handle these challenges. We hope you never need to use what you learned today, but if that day come, we believe that you'll be ready and you'll know what to do, how to protect yourself and others, and how to be part of the solution.